It's time for another edition of Valley Health Check with our friends from Horizon Health. You can always get a hold of them at myhorizonhealth.org, and mymixfm.com is where you can get these wonderful episodes where we pick, Aaron, I should say, not we. I'm just along for the ride. A different topic each and every week, and it's guaranteed relevant to you, someone you care about, or your family. I encourage you to go online and check out all these great episodes. We have a first-timer, Aaron, with us today, so why don't you handle the big intro?
Yeah, we do. Today we have Abby Snyder with us. She's a doctor of physical therapy for us at Horizon Health.
All right. Well, Abby, how you doing?
I'm well. How are you?
You're not too scared, are you?
Nope. I'm just going to wing it.
All right. I like your attitude first. You're going to do just fine, because a lot of times Aaron scares a few people.
There's a lot to unpack here. Yeah. So, Kevin, I always tell these people, the specialists, the providers, when they come in, we wouldn't do these topics if they weren't your area of specialty, right?
And
I don't have any interest making you feel uncomfortable or trying to talk about something that's out of your realm. We're truly bringing in the experts for the topics we're covering. So,
and you know what? These experts, they know what they're talking about, and you can tell they have a passion for it. They want you to learn, and they want you to know, and that's what we're doing today. So what are we going to discuss today?
Yeah.
And why don't you have you done the intro yet? I don't know what's going on.
Yeah, I said
today.
Abby's in the house.
Okay, Abby's in the house. So your last name's House.
No.
Okay.
In the house.
Oh, in the house.
Yeah.
Abby in the middle name. House
got it.
last.
Yeah.
Okay.
Yep.
Got it. It might be hyphenated. Anyway, so today Abby is going to talk to us about her role as a physical therapist, but specifically for us, she is our inpatient therapist. So she works with our patients when they're staying at the hospital. But Abby, start us off with a little bit of background. You're a doctor of physical therapy. So how does one become that? And what's your experience been?
Yeah, so education has kind of been diverse, but once I started this direction, I started at Indiana State University, and I did their athletic training applied medicine rehabilitation program. From there, I applied to PT school. I was accepted and attended High Point University in North Carolina, and I did a couple of years in North Carolina. I spent my last year in California doing my terminal clinical rotation, where I got to work at an active VA and military hospital.
Very cool.
And I kind of find my little home sweet home in critical access, and I've been in a critical access setting ever since.
Wow, that's a great story. So started out here, hometown.
Yep, Marshall native, but I needed to explore, spread my wings a little bit, but I found my way back.
That's awesome. I love when that happens. And I'm sure the hospital and everybody is happy for it.
Yeah.
And I'm sure numerous patients as well.
Yeah.
We have a sheet Aaron puts together, which, Abby, you see. And when I see something, I have no idea what it is. I'm learning right along. So I see something called the skilled swing bed. That I have no clue whatsoever. Is it illegal? No.
I hope not. We're trying to run a legal operation.
So
all
I
good
guess
things.
I'm a novice when it comes to the skilled swing bed. What is that, and how does it help patients?
Skilled is a Medicare term.
Okay.
So it's a Medicare status.
So some other people probably know, just not me.
Yeah. Well,
Okay.
and actually I think probably fewer people than you think know about it. So commonly I think it's kind of branded as rehab to home.
Yeah, we're kind of targeting our program more as a rehab to home for the name, because skilled swing bed was adopted in the 1980s, and sometimes it gets lost in translation a little bit. It can get confused. But it's ultimately just a flexible status within the hospital. So if somebody has been staying with us as an acute inpatient and they need a little more TLC, need a little extra love before they are safe to get home or back to their assisted living, wherever it may be, we're able to keep them in their same hospital room, but it just changes the billing status. It changes some of the reimbursement, but it changes none of the quality of care for the patient.
I always think that the easiest way to explain skilled or rehab to home, whichever you want to refer to it as, is kind of with an example. You know, you're like, well, I don't know exactly what that means, but Abby, can you give us a patient scenario that's common to take advantage of this setting?
Yeah, so rehab to home patients can vary a lot. We will have maybe an individual that doesn't have good home support, and they've just had a total joint replacement, and maybe they had a surgical complication, so they're needing a little bit more medical care. Maybe they have stairs and they can't climb those stairs yet to get in and out of their home. So we can bring them in, we can keep them as a rehab to home patient pending insurance approval and agreeance. Then we can,
that always happens.
Yes, but then we can do those skilled services within the hospital setting, so they've got that good nursing care, they've got the additional rehab care, so that way we can make sure that they can enter and exit their home safely. They can do everything that they need to for that next step of care, whether that's outpatient or home health, whatever it may be.
All right, here's the commonplace question from the guy that doesn't know much. Is this something that patients ask for? Is it something that the medical professionals,
Good
this
question.
is where you need to
Yeah,
go?
great question.
So that can kind of be a two-way street. So we have people come in that they know that they have had a surgery or they've had a prolonged illness and they know they are not safe. So they can ask for referrals to our Rehab to Home program. And sometimes we're seeing patients and we're like, hey, you have 4 stairs to get home. You're not even walking the hallway yet. Let's keep you a little bit longer. So it's kind of a two-way street. Providers can recommend, they can initiate the referral, the patient or their family members can also do the same.
Okay, good. So it's an option, it's out there, and people will know.
Tell me about, we're using this orthopedic example at least to get started. So tell me about what the therapy looks like then in that setting, because it does offer a little more of an intense program than you would see if you went potentially other places.
Yeah. So kind of what makes the Rehab to Home program different is statistically we're keeping our patients for 10 days or less, whereas if they go to a skilled nursing facility, that's an average of a 26-day stay. So it is a little bit more of an intense program. From the physical therapy perspective, I'm typically seeing them twice a day, 5 days a week, and then at least one visit on the weekends. So we're reaching a goal of a minimum of 150 minutes of billable exercise per week.
Wow.
So it's not always appropriate for every patient, depending on how deconditioned, depending on what their medical status is. But it is a more intense, like we're getting at least 2 30-minute sessions every day, and they know to expect me at breakfast and lunch, and we're going to get our work done.
It's got to be done, or you're not going to get back to where you need to be.
Exactly.
Again, just to kind of clarify a little, we're using that rehab to home terminology kind of as an umbrella term for both the program that we have that exists in the hospital setting and the programming that a patient would go to in a nursing home. So what we're saying there, again, with Abby's comparison of it is the same status, generally speaking. It's just when you find it in the hospital setting, it's a little more intense and it is a smidge different. So you're on that journey with your patient example. They've had the surgery, they've had the hospital stay, they're in skilled. Is there, even after they graduate from the skilled program, there's still going to be an outpatient therapy need? Is that true or not always?
So it all depends on the reason why they came to our Rehab to Home and what their ultimate goal is. So I would say more often than not, I'm able to discharge them back home to outpatient therapy services, but sometimes there may be a transportation issue. Maybe their loved one is also not very mobile, so we can also discharge them home and get them started with a home health rehab service as well. So that way maybe they can fine tune some houses. The older homes are very quirky, so I can't replicate all of those things as we're preparing to get them home, but we can get those bare basics, make sure they have the strength and endurance to get home, and then figure out what the next best option is. But rehab bias, there's always room for more improvement, so I'm going to make recommendations for home health or outpatient 99% of the time.
Now, this is an insurance-based thing, right? You have to have insurance for this?
It is. And insurance will want to see a marked progress or they discontinue the stay.
Wow, so you gotta work at it.
It's a shared workload.
No
so that's where I have to give people reminders sometimes. We have to continue showing progress, or insurance will say that this is not working for you.
Well, that's kind of a silent motivating factor, isn't it?
Yes. Yeah. So that doesn't always mean that they would be cold turkey, like, oh, you're not progressing, you got to go home and figure it out. But sometimes it just means maybe the Rehab to Home is too intense for them, and it's more appropriate for them to go to a SNF for that slower paced care if that's what they need, or maybe they are ready to go home and get back to whatever their normal baseline was.
Got you. Okay, that's very interesting. I know, Aaron, we talk about this no matter what the topic or what we're discussing, but I can only imagine family members, husbands, wives can be a great support for the rehabilitation, no matter what the scenario, rehab to home or whatever.
Yeah, I am a big advocate for including family as much as the patient wants them to be included. Ultimately, it's the patient's experience, so they're kind of driving what we do or do not do. But every week we have a weekly roundtable with all the disciplines that are involved with their swing bed care, and we kind of see, hey, what's working well? What do you still need to work on? What's your biggest barrier? If you were to go home today, what would make you the most nervous? So we include,
that's awesome.
Yeah, we include family with all of those conversations, and that way maybe the husband is the caregiver, and he's like, hey, I have to do this a lot. Can we practice this? So I do a lot of education with families so we can make sure that the spouse knows how to support them on stairs, or the grandchild knows how to help the grandparent in and out of bed, whatever it may be to get them home quickly but safely. I'll include families all day, every day, however much they want.
I love that, more of a unit to get you to where you need to be. I love the fact, though, that you kind of get a setting of how the house is and the stairs and, oh, wait, we have this little nook that goes around the corner. You kind of get the blueprint, if you will, of the challenges ahead once, they're home. Absolutely. And I love that you hit that challenge before they're there. And if you've got somebody in your family that can help that once they're there, that's a win-win, right?
Exactly. But we do have several instances where there's not family that's able to stay
I'm sure.
in the home with them. Maybe they can check in a couple times a week or once a day. So sometimes those are our bigger obstacles. We've got to work a little harder, a little bit more diligent on that. But almost every time we've had supportive family that are able to bring me pictures of the house or something. So everybody's on the same page about what obstacles we've got.
There's not too much info for you.
There's never
better,
too
right?
much. Yeah.
Yeah. It is a really cool program. And, sometimes you find these patients not ready to graduate.
Right. So I'm actually enjoying this. Come on, let me throw out my hip real quick.
Yeah. Actually, turns out the food's good here. And
those cinnamon rolls, they keep people around.
Abby, can I live here?
I feel stronger than I have in a long time. This is going really well. So, but yeah, that when you talk about those payments and insurance covering it is widely determined by the progress, and you could have too good a progress too from the patient's perspective.
Back off, Larry. You're doing way too good.
That's not a problem necessarily, right? That's
a win.
That's
really,
a win.
It's like
That's a win.
You're exceeding our expectations, and it's having to do with your livelihood and your life. That's great.
Yeah, we've had people come for as short as a 2 to 3 day stay because how they were when they left the previous facility was completely different. Once they were getting that twice a day therapy, they were able
made the difference.
Get that endurance pretty quick.
One of the things to note there, just for point of clarification too, is these stays don't have to be at where your surgery was had. They don't have to be where your hospital stay started. So in fact, big hospitals don't have this setting.
I was going to ask that.
Yeah. It is a critical access hospital. That's just our designation that we're smaller at Horizon Health. And so this is a setting that exists just in those critical access hospitals. So it is very common that we will have patients who have had their procedure, their couple days stay at a big hospital, and then they're trying to get that rehab component closer to home. That's really what these programs are made for.
Wow. I love it. I love learning something that I can see is so beneficial to the patient and can really help them along. This is really awesome. And I love that I can tell that this is something you love that you're doing.
It's a really unique experience because you have this short time to literally change somebody's perspective. A lot of times if they've had a long hospital stay, they're already a little down in the dumps. They're feeling pretty defeated. So you get to challenge them in the best way possible. And I'm sure upstairs can confirm they see me taking patients outside. We're pilfering in the garden beds. Like, we're everywhere.
That's great.
I just try to simulate those things and make them feel like they are still a person and they're worth the effort.
Good for you. That's what it's all about. And when you can just see in their face and in their physical movements that it's getting better. You can see the little light in their eye. That's got to be rewarding for you.
Yes, when they start asking for the challenges, that's when I'm like, I've done my job. I've done a good thing.
That's awesome.
Yeah. The only other thing, I guess, that I would say, just to kind of make sure we're covering all our bases as far as this skilled or rehab to home status, the largest use of that status is for things relative to Abby and physical therapy. But there are other types of patients that can also qualify for this status. So you will see patients, help me out, Abby, that have intense wound care needs.
Yep. So the common ones that I've seen since I've been there, it's largely a therapy base. So PT, OT, speech. Sometimes we'll have intensive wound care if they cannot be serviced from the outpatient setting, or home health if they need more aggressive wound care. And then a lot of times if they need IV antibiotics, those cases where they're needing it multiple times a day and they do not qualify for the outpatient setting, then they can come hang out for however long they need those antibiotics. And we'll normally tag some therapy in with those two just because you're going to be sitting a lot. So we got to keep them moving. We got to keep them well.
How would a person go by asking about this?
Yeah. So when you are at a facility, big or small, and you're getting ready to figure out what's next for you, you have a discharge planner and a care team that's figuring out the next steps for you. That's usually when the skilled or the rehab to home conversation comes up.
Okay. As soon as you mentioned that, I'm like, okay, I've had a few surgeries. I recall that. They just kind of, look back at what's next.
Yep.
Yeah.
So.
Yeah. They commonly say that discharge starts with the day of admission. You're setting setting goals, you're talking about your support system, you're figuring out a plan. And part of that plan can include this Rehab to Home program. And like Abby said, whether or not your discharge planner brings it up, whether or not the family asks if it's an option, all of those things are ways that it can come to be.
Another podcast where I've learned about something that is so beneficial to so many. Abby, that's awesome. Well, Abby, how do you feel after your very first podcast? Feel good about it?
I'm fine.
You are good. Abby, you're
killing
awesome.
it over here.
Oh, she's a pro, and she's only done one. Look at this. Well, keep up the good work. We appreciate you being part of this Valley Health Check. Of course, we talk about so many different things. We encourage you to go to mymixfm.com. You can even check out our Mix FM app and listen to these episodes. And you know what? They roll one right into another. You would be surprised of all the stuff you can learn. And it's all thanks to our friends from Horizon Health. Well, Erin, Abby, a pleasure. Thank you for everything, ladies.
Thanks, Kevin.
For having us.